So, yes. Good evening to all. I welcome all the teachers and the students. Today we have the Bodhana series topic of cardiovascular disease complicating pregnancy. என்னாச்சு?
கேக்குது மேடம்.
எனக்கு பிக்சரே இங்க தெரியல. Anyway, I request our president Dr. Anjalakshi madam to give the welcoming address. Madam, நீங்க ஸ்டார்ட் பண்ணுங்க. நான் அதுக்குள்ள என் ஸ்கிரீன்
Okay. Good evening to everyone. Thank you, Sambat.
Yes, madam.
Actually, I'm very happy that today we have the 8th Bodhana program, which has been successfully running. And the topic for today is the heart disease and the vascular disease complicating pregnancy. And for that, we have the eminent teachers from the home institution, Dr. Tangatha and Dr. Bhagyalakshmi, and the external teachers, Dr. Sita Panikar and Dr. Rani. I request all the postgraduates to take this wonderful opportunity to clear all the doubts in the heart disease. Heart disease, actually, it is gaining importance and it is a threat to the safe motherhood. And it constitutes about 10% of the maternal mortality. In the United States itself, the mortality rate is high, 4.23 per 100,000 live births. So there is increased, the maternal mortality is because there is a failure to identify the disease and also the risk factors and a gap in the intrapartum care and also recognition of the disease in the postpartum stage. So I request all postgraduates to learn carefully and make this subject, which is supposed to be very tough, make it easy, you can understand well. So you should differentiate the physiological changes of the cardiovascular system from the heart disease and should be able to diagnose the cardiovascular disease and give a proper antenatal care, identifying the risk factors and a close intrapartum care with a multidisciplinary approach. Dear students, kindly make use of this opportunity and drive away your fears regarding the heart disease. You can improve the intranatal care and the postpartum care and reduce the there should not be any maternal mortality because of the heart disease. So with these words, I welcome all the teachers and the students and kindly continue with your proceedings. Thank you.
Thank you, madam. Kalpana.
Ma'am.
See, for this program, our coordinator is Dr. Kalpana. I request Dr. Kalpana to read the CV of all 4 teachers and the student.
Good evening, everyone. I welcome you all for this wonderful Bodhana 8th PG training program. We have learned teachers, externals and internals to train our PGs. I welcome Bhagyavati madam, who is associate professor in OG department, Government Medical College, Trichy. Madam has Madam was an assistant professor in Trichy 2007 to 12 and senior resident Government Medical College Trichy 2006 to 7. Madam has various publications related to sublingual misoprostol 200 microgram with intramuscular carboprost 125 microgram in the active management of 3rd stage of labor. And madam has also done a study about sublingual versus vaginal misoprostol 600 microgram for cervical ripening in the 1st trimester abortion. Welcome you, ma'am.
Thank you, madam. Thank you, madam.
I welcome Tangattai ma'am, who is a professor, Government Medical College, Trichy. Madam was now professor in Trichy Medical College and madam was professor in Tanjavur Medical College 17 to 18 and also Pudukkottai Medical College 18 to 19 and Tiruvarur Medical College 19 to 20. And she was an associate professor in Trichy 12 to 15, Tiruvarur Medical College 15 to 16, Tanjavur Medical College 16 to 17. Welcome you, ma'am. Our external is Sita Panikar, madam. who is now professor in OG department, PSG Medical College, and her affiliations are past president, managing committee member, Kobai OG Society, member of institutional ethics and HICC committee, core group member of medical education technology cell. Madam was certified in colposcopy by International Federation of Cervical Pathology and Colposcopy, and EC member of Indian Society, ISCCP. She has received a Best Doctor Award by MGR University, and also received a Faculty of Advanced Life Support in Obstetrics affiliated to AAFP. Madam had already published many publications in national and international journals, and she was an invited speaker at national and international conference. She was in scientific committee member of TNFOG 2019. Madam's special interest is preventive oncology, high risk pregnancy, and bioethics. Welcome you, ma'am.
Thank you, ma'am.
Our next external is Rani ma'am, who is a professor IOG Egmore. Madam did undergraduation in Madras Medical College, post-graduation in Kilpak, and she is an undergraduate and postgraduate teacher, has presented many papers in national and international conferences. Welcome you, ma'am. Now we have PG from Muthukumaran Medical College, who is going to present about heart disease in pregnancy. She is a third year postgraduate in OG department, MBBS in Muthukumaran Medical College, and now doing MS OG in Trichy Government College. Dr. Archana, and so we
Archana,
have
no Archana.
oh,
Archana, Satyapriya.
no, previously.
Okay, no problem.
Okay, Priya is going to present about heart disease complicating pregnancy, who is a third year PG in Trichy Medical College. Satyapriya?
Yes, she is there, I think. Satyapriya and Priya, both of them are together, Kalpana. Thank you, Kalpana.
Okay.
Kalpana, இன்னொரு பாயிண்ட் நீ சொல்ல மாட்டா. ராணி பேர் சொன்னாலே அதுரும். பயங்கர ஸ்ட்ரிக்ட் டீச்சர்.
இப்படிலாம் சொன்னா அவங்க பிரசன்ட் பண்ணவே பயப்படுவாங்க மேடம்.
அப்படிலாம் இல்ல, நாள பண்ணணும், அதுக்காக தானே சொல்றது. எஸ், எங்க அந்த பசங்களை காணுமே. சத்யபிரியா, பிரியா
மேம், நான் இங்க லைன்ல தான் இருக்கேன். சத்யபிரியாவும் இருக்காங்க. சத்யபிரியா
மேம், அவங்களுக்கு ஆடியோ இஷ்யூஸ் இருக்கு மேம்.
டாக்டர் அர்ச்சனாவை பண்ண சொல்லுங்க மேம். மேம், டாக்டர் அர்ச்சனா will do otherwise.
அர்ச்சனா வேற எது? சரி, யாரோ ஒருத்தர்
சத்யபிரியா மேம், நாங்க பேசுறது கேக்குதுல மேம்? ஜஸ்ட் கிவ் யூ thumbs up symbol.
ஆளே தெரியல பிரியா.
சித்திரகலா அவங்க பண்ண முடியலன்னா டாக்டர் அர்ச்சனா
இல்ல மேம், அவங்களால பேசவே முடியல. அவங்க ரெண்டு பேரும் ஒன்னாதான் உட்கார்ந்துருக்காங்க.
மேடம் சத்யபிரியா, பிரியா கை தெரியுதா? பேசுங்கப்பா.
சத்யபிரியா மேம், அந்த ஆடியோ ஐகான் மாதிரி இருக்குல்ல, அதுல ஒரு சின்ன அப் ஆரோ இருக்கும், அத கிளிக் பண்ணுங்க. அதுல சேமா சிஸ்டம்னு கொடுங்க. மைக்ரோஃபோன்லயும் சேமா சிஸ்டம் கொடுங்க, ஸ்பீக்கர்லயும் சேமா சிஸ்டம் கொடுங்க. இப்ப ட்ரை பண்ணுங்க. ஓகே, ஹெட்செட் வச்சு ட்ரை பண்ணி பாருங்க. இல்ல மேம், இன்னும் பேசுறது கேட்கல. சோ மொபைல்ல ஜாயின் பண்ண முடியுமா பாருங்க. மொபைல்ல ஜாயின் பண்ணுங்க, லேப்டாப்ல பிரசன்ட் மட்டும் பண்ணுங்க. மொபைல்ல சேம் லிங்க் கிளிக் பண்ணி பாருங்க. அது வரைக்கும் நீங்க ஷேர் ஸ்கிரீன் வருதான்னு செக் பண்ணுங்க மேம். ஷேர் ஸ்கிரீனும் வரலையா மேம்? மேம் நான் என்னோட நம்பர் டைப் பண்றேன், எனக்கு கால் பண்ணுங்க இன் சாட் பாக்ஸ்.
சத்யபிரியா, நீ எதுல லாகின் பண்ணிருக்க?
லேப்டாப்ல தான்.
லேப்டாப்பா?
லேப்டாப்ல தான் மேம் லாகின் பண்ணிருக்காங்க. இப்போ உங்களால பார்க்க முடியுதா மேம்?
வீடியோ தெரியுது.
வீடியோ தெரியுது மேம், பட் அவங்க பேசுறது கேட்கல மேம். எஸ் மேம். சத்யபிரியா மேம் இப்ப பேசுங்க. யூ ஹவ் டன் சம்திங். இதுக்கு முன்னாடி உங்களோட இதுல ஏதோ சவுண்ட் வந்துச்சு. மேம் ஒண்ணும் இல்ல, அந்த மியூட் ஐகான் பக்கத்துல ஒரு சின்ன ஆரோ இருக்குல்ல மேம், அதை கிளிக் பண்ணுங்க. சேமா சிஸ்டம் இருக்கா? ஓகே, இப்ப மைக்ரோஃபோன் இல்லனா மாத்தி பாருங்க. ஜஸ்ட் சேஞ்ச் தி செட்டிங்ஸ் ஒன் பை ஒன்னா சேஞ்ச் பண்ணி பாருங்க. நோ, கேக்கல.
Ma'am, are we audible now, ma'am?
Yes, perfect.
Yes, ma'am.
Okay.
Okay, இப்ப ஸ்லைட் ஷேர். ஸ்லைட் ஷேர் பண்ணுங்க.
One second, ma'am. Ma'am, is it now?
No. அந்த கீழ ஷேர் ஸ்கிரீனை கிளிக் பண்ணிட்டு எஸ் ஸ்டார்ட்.
Is it now?
Yes.
Yes, ma'am. Ma'am, good evening to one and all, ma'am. I thank
ஸ்லைட் ஷோவா தெரியல மேம். ஸ்லைட் ஷோவா தெரியல. மறுபடியும் ஸ்டாப் ஷேர் பண்ணிட்டு சேம் ப்ராசஸ் பண்ணுங்க மேம். நீங்க என்ன? Perfect.
Okay, ma'am. Shall I start, ma'am?
Yes, ma'am.
Yes.
Ma'am, good evening, ma'am. I thank one and all for giving me this opportunity. I'm today presenting a case on heart disease complicating pregnancy, ma'am. Mrs. G, 21 years of age, wife of B. She's a homemaker, studied BSc Microbiology of Socioeconomic Class 4, coming from Nuthapur. Booked and immunized at Pasumpalur PHC. COVID vaccination 2 doses taken. She's a 21 years primey, married for 11 months, regular cycles. Her LMP is 10/6/21. Her EDD is 17/3/22. Her gestational age is 35 weeks 5 days. She's a known case of rheumatic heart disease, moderate MS, mild MR, status post PTMC for the past 9 years. History of presenting illness. Patient came with scan findings showing fetal growth restriction and oligohydramnios. She's able to perceive fetal movements well. No history of lower abdominal pain. No history of bleeding PV. No history of draining PV. No history of breathlessness belonging to class 1 NIHA. No history of easy fatigability, palpitation, chest pain, orthopnea, PND, syncope, or fever, swelling of legs, cough with expectoration, or hemoptysis. History of present pregnancy, first trimester. She conceived after 2 months of marriage, spontaneous conception. Pregnancy was detected by UPT at PHC after 45 days of amenorrhea. Booking and immunization done at Pasumpalur PHC. Total number of AN visits was 11, 9 visits at PHC and 6 visits at GH. She was started on tablet folic acid and was taken regularly. And dating scan was done at 8 weeks and pregnancy was confirmed and was corresponding. No history of hyperemesis, no history of abdominal pain, bleeding PV, draining PV, no history of breathlessness belonging to class 1 NIHA, no history of easy fatigability, palpitations, chest pain, orthopnea, PND, syncope, fever, swelling of legs, cough with expectoration, or hemoptysis. No history of drug intake, no history of radiation exposure. Her basic blood and urine investigations were told to be normal. Her HB was found to be 11.2 grams in her first trimester. GCT was done at 12 weeks and it was 94 milligram per deciliter, and her BP recordings were told to be normal. She was referred from Pasumpalur PHC to Trichy GH at 8 weeks of gestation. She was admitted and evaluated at GH, and cardiology opinion was obtained. Her echo findings were status post PTMC, AML and PML were found to be thickened, PML mobility restricted, AML doming present, and MVA was 1.3 centimeter square. It was diagnosed as moderate MS, mild MR, trivial TR, no ASR AR, no PAH. Her ejection fraction was 63%. She was advised to continue tablet penicillin, tablet furosemide, and she was advised for regular follow-up. Second trimester.
I think we'll go trimester wise. Go back to the first slide of the first trimester.
Yeah, ma'am.
Okay. So if she comes to you for her first antenatal visit at 8 weeks, you have confirmed pregnancy. So what is important as regards the heart disease?
Ma'am, we'll have to evaluate her, and first we have to evaluate her cardiac condition, ma'am. We have to see.
So symptom wise, what is important?
First, foremost important symptom is dyspnea, ma'am. So we'll have to classify her according to the NIHA classification, ma'am. We'll have to see in which class she belongs to. If she belongs to class 1, then she will be asked to come for regular follow-up, ma'am. If she is in class 3 or 4, yes, ma'am.
Now, if she is in class 1, you're happy. But does it mean that she will continue to remain class 1?
No, yes, ma'am. Okay. She will, as the pregnancy progresses, she may go up a class in NIHA, ma'am. She may go on to class 2 or class 3. So she has to be evaluated in her every visit. Every visit she has to be.
So that is very, very important, because she belongs to class 1 NIHA at the first antenatal visit does not mean that she will continue to remain class 1. So pregnancy is actually a natural stress test for the heart, isn't it? So as pregnancy advances, she may, fall in her NIHA class. Now, if she was a multi-gravida, will something give you a hint whether she will progress in her,
Ma'am, we have to ask her previous pregnancy history, ma'am, whether there were any cardiac events in her previous pregnancy, whether she was, based on her history, we can predict whether she was progressing worsen, whether it worsened as her previous pregnancy progressed, whether we can ask for any history of PTCM or and such, ma'am.
Okay, so previous pregnancy, if she has worsened during pregnancy, you can expect the same thing in this pregnancy.
Yes,
but if it did not happen, still you can say that sometimes because of advancing age and worsening stenosis, she could still sort of progress. Next slide. Okay.
Shall I continue?
Now, okay, all these are symptoms which are seen in very, even in normal pregnancy. Many pregnant patients will complain of a little bit of breathlessness. So what are the symptoms which are very important, which should raise a red flag?
Ma'am, progressive dyspnea is one thing. Dyspnea as such is common in pregnancy, but progressive dyspnea should be is a warning sign, ma'am. And also PND or hemoptysis.
Okay, wait. So dyspnea, progressive dyspnea, orthopnea, and PND. These are very, very important. Yes?
Yes, ma'am.
Palpitations. Many pregnant patients complain of palpitations, no?
Yes,
so what is important? Palpitations associated with fainting. If she feels that she's about to faint or something, it may be a pointer towards what?
Towards worsening of her cardiac.
Some arrhythmia. Okay, so what arrhythmia is associated with your, mitral stenosis? What is the commonest arrhythmia?
AF, ma'am.
AF, atrial fibrillation. Okay.
Yes, ma'am.
Then what are the other important symptoms? Chest pain is definitely abnormal. Okay.
Yes,
similarly, hemoptysis. Okay.
Yes, ma'am.
Next slide. Okay, now explain this echo findings to us.
Ma'am, it has this echo findings is post her PTMC, ma'am.
What is PTMC?
So in this, PTMC is percutaneous transvenous mitral commissurotomy, ma'am.
Okay, so it was an open percutaneous, huh?
Yes, ma'am. Transvenous, ma'am.
Okay.
So the echo findings showed a mitral valve area of 1.3 centimeter square, ma'am. So that
Okay.
falls under moderate mitral stenosis, ma'am.
Moderate. Okay. So what is
Yes, ma'am.
severe mitral stenosis? What is the normal area of the mitral valve?
4 to 6 centimeter
4.
square, ma'am.
4. Okay.
4, ma'am.
Okay. So severe is?
Severe is when it is less than 1 centimeter square,
Less
ma'am.
than 1 centimeter square. Okay.
So and but
this
ejection
anterior and
fraction
posterior
was-
mitral leaflet are thickened, isn't it?
Yes, ma'am.
Does it have any significance?
Ma'am, it shows that it is a signifies that it is a post-traumatic fever changes, ma'am. Post-traumatic heart. It means that rheumatic fever with valvular involvement is present, ma'am.
Okay. If it is also calcified, does it have any significance? Thickened and calcified.
Ma'am, it denotes that it's a worse condition.
Okay, now
It is
the
a severe
patient may
condition.
not be fit for a percutaneous balloon mitral valvoplasty, which is one thing which can be done during pregnancy without much complications. So the valve leaflet state will help you to different. So what are the important things which you look for in the echo finding? The cardiologist actually does the echo and gives the report to us. So what are the important things that you have to look for in a patient with mitral stenosis? One you said is the valve area.
Valve area,
Okay.
ma'am. We'll have to
Okay.
look for any pulmonary hypertension, ma'am.
Okay,
And we'll
very
have to
good. So
look for-
pulmonary hypertension. Okay, then
And ejection fraction, ma'am.
ejection fraction. Anything else?
What about chambers?
Very good.
Yes,
What
we'll
about
look
the
for any
chambers?
dilated chambers, ma'am.
Which
one?
chamber gets dilated?
In
Ma'am,
mitral
left atrium gets dilated, ma'am.
Very good. Okay.
can happen inside the left atrium. Secondary to
Ma'am,
the
there is a volume as in normal, as such in a normal pregnancy there's a volume overload, ma'am. In a case of mitral stenosis, because of the stenotic lesion, there is stagnant blood, there is a stagnation of blood in the left atrium, ma'am. So resulting in left atrial dilatation, ma'am.
and subsequently
Subsequently, it may go on to atrial fibrillation or pulmonary edema or even thrombotic events, ma'am. Thrombosis,
you
ma'am.
have a thrombus. You have to look for a thrombus at the left atrium in your echo.
Yes, ma'am.
Now, why does mitral stenosis worsen in pregnancy?
Ma'am, the condition is the hemodynamics of mitral stenosis is quite similar to the physiological changes in pregnancy, ma'am.
Okay, so what physiological change will worsen mitral stenosis in pregnancy?
Ma'am, one is that physiological changes, it is a hyperdynamic state, ma'am. Another thing is cardiac output increases in pregnancy, ma'am. It starts from 6 weeks of gestation. It goes to the maximum at 28 to 32 weeks, ma'am.
No, actually in mitral stenosis, there's a fixed cardiac output. Cardiac output does not increase. So what increases? In normal pregnancy, it increases. But
Yes,
here, what increases, which worsens the pulmonary congestion?
Because of left atrial pressure increases, ma'am. So pulmonary venous congestion
Now, in
occurs.
pregnancy, what increases to increase the pulmonary congestion? Blood volume. Blood volume increases.
Yes, ma'am.
So
Yes,
preload increases. So because of preload and the amount of blood which can go through a stenosed mitral valve is less. Okay, so that is why there is damming back of blood in the pulmonary circulation and pulmonary congestion increases in mitral stenosis. And what is the other physiological change which is important? Pregnancy, what happened?
Ma'am, decreased peripheral vascular resistance, ma'am.
Decreased peripheral vascular resistance is actually an advantage.
Yes, ma'am.
One more thing, tachycardia.
Yes, ma'am. Tachycardia, yes, ma'am.
So tachycardia reduces the diastolic filling time. So because of that, again, there is increased pulmonary congestion. So the two important physiological changes in pregnancy are, one is the increased blood volume, increased preload with a fixed cardiac output. So pulmonary congestion increases. Similarly, tachycardia reduces the diastolic filling time. On the other hand, if you have mitral regurgitation, it actually improves during pregnancy. Why?
Um,
Because of that physiological change that you mentioned.
Already mentioned.
decreased peripheral vascular resistance.
Very good. So decreased peripheral vascular resistance. So there is increased forward flow. So the amount of blood which is regurgitating becomes less. That is why actually mitral regurgitation does not worsen during pregnancy. Okay. Yes. Can we continue?
Yes, ma'am.
Yes, continue.
Okay, ma'am. In her second trimester, weakening was felt at 5 months of gestation. Anomaly scan done at 20 weeks and was found to be corresponding to her GA. Fetal echo was done and was found to be normal. No history of abdominal pain, bleeding PV or draining PV. No history of breathlessness. She still belongs to class 1 NIHA. No history of EC fatigability, palpitations, chest pain, orthopnea, PND, syncope, fever, swelling of legs, cough with expectoration or hemoptysis. No history of dysuria, no history of headache, blurring of vision, decreased urine output or excessive weight gain. A repeat echo was done and was found to have similar findings, and she was advised to continue the same drugs that she was already on, and her blood and urine investigations were found to be normal. Her hemoglobin was found to be 10.8 and her GCT was found to be normal and BP recordings were normal. GCT done at 20 weeks was found to be 112 milligram per deciliter.
So in the second trimester, what are the 3 things that you must keep normal in order to reduce the strain on the heart?
One is anemia, ma'am.
Anemia, very good. Next.
Other thing is BP should be under control, ma'am.
Okay, so you have to monitor the BP. If she develops pregnancy-induced hypertension, then of course the strain on the heart is worse. And one more?
Infection.
You have mentioned. Okay. Excessive weight gain. So she should not have excessive weight gain. Okay, so infections also again increase the load on the heart. So what infection should you look for?
Any UTI, ma'am. Urinary tract infection or respiratory tract infections, ma'am.
Okay. Okay. Yes.
Shall I continue, ma'am?
Yes, continue.
Ma'am, third trimester, she had regular AN visits. Iron and folic acids were taken. She was able to perceive fetal movements well. No history of abdominal pain, bleeding PV or draining PV. No history of breathlessness. She still belongs to class 1 NIHA. No history of EC fatigability, palpitation, chest pain, orthopnea, PND, syncope, fever, swelling of legs, cough with expectoration or hemoptysis. No history of dysuria.
Why are you
no
asking for fever? Just incidentally, I'm asking every visit. Why fever?
Ma'am, fever, we'll have to look for any infective endocarditis if possible. I mean, it is also one factor which can worsen the cardiac condition, ma'am. So asking for fever, ma'am.
Infective endocarditis, recrudescence of rheumatic fever, or any other infection. So 3 things can cause fever. Okay.
No history of dysuria, no history of headache, blurring of vision, decreased urine output or excessive weight gain, no history of radiation exposure. Her blood and urine investigations were found to be normal. GCT at 32 weeks was 94 milligram per deciliter. Follow-up echo was done and she was started on tablet metoprolol 25 mg along with other drugs. She was advised to avoid fluid overload. Interval scan at 35 weeks showed a GA of 30 weeks in all her BPD, FL and AC, and oligohydramnios of 6 to 7 centimeters, and doctor suggested uteroplacental insufficiency, following which patient had come for admission and evaluation at MGMGH Trichy, ma'am.
Okay. Okay.
Shall I continue, ma'am?
Continue.
Her past medical history. Patient was apparently normal till 13 years of age. In 2013, she had history of fever with multiple joint pains. For 10 days, she had history of palpitations and breathlessness on exertion, which was present for 10 days, following which she was taken to a private hospital in Chinnasalem, where ECG was taken and she was advised to consult a cardiologist. So she was taken to the cardiology department in MMC Chennai, ma'am.
Okay.
And she was found to have rheumatic heart disease with severe MS and severe pulmonary hypertension. So percutaneous transvenous mitral commissurotomy was done within 2 weeks of admission, ma'am. Her pre-dilatation MVA was 0.9 centimeter square and post-dilatation was 1.37 centimeter square, ma'am. Her post-operative period was uneventful and post-PTMC echo showed moderate MS mild MR, and mild pulmonary hypertension. She was advised to continue tablet penicillin. Post procedure, she had no complaints of breathlessness, palpitation, or easy fatigability. She was on regular follow-up at MMC till 2017 and continued follow-up at a private hospital in Kallapurichi. She discontinued her medication in 2019, and during her follow-up echo in 2020, it was showed as moderate to severe MS, moderate MR, and she was restarted on tablet penicillin furosemide. Ever since, she has been on regular follow-up. And after her conception, she has been on regular follow-up at Trichy GH since July 2021. She is not a known case of diabetes, hypertension, tuberculosis, bronchial asthma, epilepsy, thyroid disease, or STD. She has no history of any blood transfusions or chronic medication, no history of any drug allergy, no history of any other surgeries other than PTMC.
Okay.
Shall I continue, ma'am?
Okay. So actually, preconception counseling is very, very important in heart disease now, isn't it? So
Yes,
did she have that preconception counseling?
Ma'am, the patient, she told that she had a she consulted a cardiologist before during her marriage, ma'am, at the time of her marriage, and she was advised to follow the drugs, and she was advised to
Okay, so what is the importance of preconception counseling? What and all can you advise her during this time?
Ma'am, first at the preconceptional counseling, first we'll have to evaluate her cardiac status at that time, ma'am. We'll have to first look at her functional cardiac status and the nature of the cardiac disease, ma'am. And based on that, if at all, based on her modified WHO and her NIHA classification, if at all she falls under NIHA modified WHO risk of class 4, she is advised against pregnancy, ma'am. And
Okay,
if she
very
belongs
good.
if she belongs to class 1 NIHA, then she is advised to continue her pregnancy, but she should be warned about the risk that she is going to undergo with in a pregnancy with a cardiac disease, ma'am.
Okay, so you can tell her what condition pregnancy is contraindicated. Next, you can also see if she belongs to class 2 or 3, NIHA class 2 or 3, and she has a correctable lesion, surgically correctable lesion.
It has to be corrected, and then she's advised to conceive, ma'am.
Okay, so to identify surgically correctable lesions. Any other importance of preconception counseling?
Ma'am, genetic counseling is of significance. So in case of any congenital heart diseases, the possibility of inheritance to the next offspring should be told to the patient, ma'am.
Okay. Okay.
What medications?
And the medications that has to be avoided during pregnancy, ma'am. There are certain cardiac drugs that should not be advised during pregnancy, ma'am.
Now, suppose she had a mitral valve replacement.
Yes, ma'am. Yes, ma'am. In case of mitral, yes, ma'am. She must have already been on warfarin, which has to be discontinued and started with heparin, ma'am. Because
so you can adjust. It's not always required.
What valve she has, you have to find out first, no?
Okay, ma'am. And
so
the proper
advise her regarding
Yes, ma'am.
Okay, so you have to advise her regarding the ideal anticoagulant, how to adjust it, what is the dose of warfarin. If it is above 5 milligrams, you may have to stop it. Okay, so these important things can be done during the preconception counseling.
Yes, ma'am.
Shall we continue, ma'am? Okay.
Her menstrual history, age of menarche is 13 years of age, regular cycles, 3 of the 28 cycles, and she changes 2 to 3 pads per day, not associated with pain or clots. Her LMP is 10/6/2021. Marital history, she has been married for 11 months, non-consanguineous marriage, no history of any contraception. Family history, no history of any heart disease, hypertension or diabetes, no history of congenital anomalies or multiple pregnancies, no history of preeclampsia in mother or siblings. Personal history, she has a mixed diet, normal bowel and bladder habits, sleep and appetite are normal, no history of any drug abuse, smoking or alcohol. General examination, patient comfortable at rest, not dyspneic or tachypneic, moderately built and nourished. She's not anemic, icterus, No cyanosis, clumping or pedillerema or generalized lymphadenopathy. JVP was not elevated and her gait is normal. Her thyroid, breast and spine are found to be normal. Her height is 146 centimeters and her weight is 58 kgs and her BMI is 27.2. Her pre-pregnancy weight was 50 kgs and her weight during pregnancy, weight gain during pregnancy is 8 kgs.
Okay.
Her
So in
vitals, yes ma'am.
she's not tachypneic. It's better to count the respiratory rate and say what it is. Okay.
Yes, ma'am. Yes, ma'am. In my her BP it was 170 mmHg, measured in the right upper arm in sitting position, and her pulse rate is 76 per minute, regular in rhythm, normal volume, no specific character, felt equal in all peripheral pulses, no radial or radiofemoral delay, no vessel wall thickening. Her respiratory rate was 18 per minute, and her saturation is 99% in room air, and her temperature is 90 degrees Fahrenheit. Systemic examination, cardiovascular examination,
Priya,
inspection.
1 minute. Sita,
Yes,
madam.
Mm.
Can you repeat that preconception counseling again, madam? Somebody has asked in the chat box.
Okay. I saw that. I thought at the end we'll answer all the questions, but anyhow, we'll finish the preconception counseling. So preconception counseling has now become very important in patients with heart disease. First of all, most importantly, as she told, you have to identify patients for whom pregnancy is contraindicated. So if they belong to the WHO group 4, where pregnancy is associated with a mortality of almost 25 to 50%, pregnancy is contraindicated. Can you give me an example of group 4?
Ma'am, coarctation of aorta, Marfan's with aortic root
Coarctation of aorta with the dilated aortic root, or pulmonary hypertension.
pulmonary
Okay, so
hypertension.
second is to assess what is the heart disease, what is the functional status of the heart, and to see if any corrective surgery is possible. For example, if there is severe mitral stenosis with a valve this thing of less than 1, you can offer preconception corrective surgery, which is safer than which is something which is done in pregnancy. Thirdly, in patients with heart disease, that is congenital heart disease, you can also discuss the inheritance. So what is the percentage of ASD, VSD, or for example, Marfan syndrome, which has it's an autosomal dominant condition, which has a 50% chance of inheritance. Then you have to assess what are the drugs the patient is on. Now, certain drugs are contraindicated in pregnancy. For example, ACE inhibitors and all. If she's on, you can change the drug. And of course, anticoagulants. If she's on anticoagulants, you have to adjust what can be done. Warfarin, sometimes if the dose is less than 5 milligrams, you can continue with after describing the risk of possible warfarin embryopathy. Or if you can convert it into heparin in the first trimester. So all this, if it is discussed before conception, it would be much easier.
Shall I continue, ma'am?
Thank you, ma'am. Satya Priya, you can continue.
Systemic examination, cardiovascular examination, inspection, chest wall symmetrical, no kyphoscoliosis, trachea in midline, no suprasternal or supraclavicular pulsations, JVP not elevated, no scars or sinuses in the chest wall, no dilated veins, no precordial bulge, no parasternal heave, apex beat not visualized.
No, see, go back. Certain things are not, these are not inspection. Parasternal heave is a palpatory finding. Okay, so cardiovascular examination is very important in this patient. It has to be inspection, palpation, everything has to be done. But some of this is not actually, parasternal heave is a palpatory finding. Describe how you will check for JVP.
Ma'am, patient is asked to lie in the supine position with a 45-degree tilt, and she
Not supine.
45-degree
tilt
inclination, ma'am.
No, when you say supine, it means flat.
Lying flat. No?
Okay, ma'am. Okay, ma'am, with a 45-degree inclination, ma'am. And head is turned towards the left side, and the JVP is measured, ma'am. From the sternal.
How? Mhm.
Ma'am, it is measured from the sternal border to the upper venous
Sternal
column. ma'am.
border.
And
What is that second? So you have identified where is the JVP which is seen in the neck. Then you have a scale which is placed
ma'am, placed from the
vertically.
yes, ma'am, from the sternal border to the it is placed vertically up to the end of the pulsation, ma'am.
So how many scales you need? Actually, I don't have.
Two scales are needed, ma'am. Two scales are needed, ma'am.
One should be.
If you can see one scale is kept like this, then this thing is
Another perpendicular to that scale, another scale is placed.
and
And
this
it is
will
measured
give you
up
the
to
height of the JVP.
JVP, ma'am.
Okay. Palpation.
Yes, ma'am. Palpation tracheal position is confirmed to be in the 4th intercostal space in the mid-clavicular line. Carotid pulsations are felt and no
Tracheal
precordial
position.
Tracheal position, Amma.
Sorry, ma'am?
Trachea is in the
What
midline
position
of the
does it
neck. No?
confirm? The apex.
Sorry, ma'am. Trachea position to be. Sorry, ma'am. I have made us. I don't know, ma'am. There's a small mistake, ma'am. Tracheal position confirmed. And the apical impulse is found to be in the 4th intercostal space in the mid-clavicular line, ma'am. Sorry, ma'am. There has been a-
Okay.
Yes, ma'am. The carotid pulsations are felt and no precordial thrill, no parasternal heave or no palpable sounds.
Okay, so palpation, you must look for these 4 things. One is the apical impulse. See if there is any precordial thrill, parasternal heave, and palpable sounds, usually palpable P2. Okay, so
Yes,
these 4 things you look for, plus of course the tracheal position. Yes.
Yes, ma'am. Auscultation. S1 and S2 are heard in all areas. Loud S1 is heard in the mitral area. Low pitched, rough, rumbling, mid-diastolic murmur in the mitral area of grade 3 with no radiation, with a pre-systolic accentuation ending in loud S1. There was no opening snap present in this patient, ma'am, and there was loud S2 heard in the pulmonary area.
Okay.
Shall I
Okay,
continue,
so,
ma'am?
okay, so tell me about auscultation. What are all the things you'll discuss? This is a typical murmur that you have described in mitral stenosis. You know the diagnosis, therefore you're able to describe the murmur. But generally, what are the important things you look for in any murmur? Where it is best heard, which area it is best heard, then what else?
Whether there is any radiation to the other areas. And we have
First
to
of all, whether it's a systolic murmur or a diastolic murmur.
Yes,
Okay.
ma'am. And then we'll have to grade the murmur, ma'am.
What is the loudness? Okay.
Yes, ma'am. And then we'll have to look for any if there is any radiation.
Radiation. Okay, so why it's given importance is because some murmurs are physiological in pregnancy.
Yes, ma'am.
Okay, you can have, if you have a soft systolic murmur over the pulmonary area, it's usually taken as physiological. So what are the murmurs which are definitely pathological?
Ma'am, diastolic murmur.
So any diastolic murmur, very good. So any diastolic murmur is pathological then?
Or grade 3 of systolic murmurs.
Then grade.
Or pan-systolic murmurs, ma'am.
Okay, so anything more than grade 3 systolic murmur is also pathological. Okay.
Shall I continue, ma'am?
Continue.
Respiratory system, bilateral normal vesicular breath sounds, no added sounds, no basal crepitations. Central nervous system, no focal neurological deficits. Obstetric examination, inspection after getting consent from the patient and emptying the bladder, patient in supine position. Parts exposed from the pubic symphysis to the xiphisternum, uterus longitudinally enlarged, stria gravidarum and linea nigra present, no scars or sinuses present. Palpation after correcting the dextrorotation, symphysiofundal height was found to be 30 centimeters and abdominal girth of 8 to 6 centimeters. Fundal height corresponds to 30 weeks of gestation. Her fundal grip, soft, broad, non-independently ballotable part palpable, suggestive of reach. Her first pelvic grip, hard, round, independently ballotable pedal part felt, suggestive of head. Clinically, Riker seemed to be reduced. Auscultation, fetal heart rate of 146 to 150 beats per minute, regular in rhythm and volume, good tone, heard along the left spino-umbilical line. Local examination.
Doctor, go back to the previous slide. You have not
Ma'am?
mentioned whether the head is mobile or.
Ma'am, it was a mobile head, ma'am.
Yeah.
Mobile head. Auscultation, fetal heart rate of 146 to 150 beats per minute, regular in rhythm and volume, good tone, heard along the left spino-umbilical line. Local examination, no abnormal discharge PV. Perspiculum examination, cervix appears normal, no abnormal discharge PV. Per vaginal examination, cervix uneffaced, firm, posterior, os closed, head at -3 station, sacral promontory could not be reached, sacrum well curved, sacroaortic notch admits 2 fingers, pelvic side walls parallel, ischial spines not prominent, pubic arch well curved, pubic angle obtuse, ischial tuberosities admits 4 knuckles.
Why did you do a vaginal examination?
Ma'am, since she's a primary gravida and she's come with a fetal growth restriction, ma'am, so we'll have to plan her further obstetric treatment management, ma'am. So I wanted to assess her pelvis if in case labor, if we are going to continue with her, whether we're going to terminate the patient, ma'am.
So actually in patients with heart disease, you should not do vaginal examination unless it's absolutely indicated. If you're planning to induce her tomorrow, you can do the vaginal examination. Otherwise, generally, you should not do an unnecessary vaginal examination in patients with heart disease. Because if you do this, okay.
Okay, ma'am. A summary. Mrs. G, 21 years, a homemaker, studied BSc Microbiology belonging to Socioeconomic Class 4, coming from Pasumpalur, Primary, married for 11 months, regular cycles, booked and immunized at Pasumpalur PHC. Her LMP is 10-6-21 and her EDD was 17-3-22, GA of 35 weeks, a known case of rheumatic heart disease, status post PTMC, moderate MS, mild MR, belonging to type 1 class 1 NIHA, on tablet penicillin 250 mg PD, tablet furosemide of 20 mg OD, tablet metoprolol of 25 mg OD, not in failure, with no significant family history, with general examination findings of being comfortable at rest, moderately built and nourished, vitals with no signs, vital stable with no signs and symptoms suggestive of cardiac failure, embolism or arrhythmias, systemic examination within normal limits, obstetric examination findings showing a uterus not corresponding to her gestational age, single live fetus in longitudinal lie of cephalic presentation with clinically Leica reduced, has now come with scan findings showing fetal growth restriction and oligohydramnios for evaluation and further management. Diagnosis: 21 years, primary, married for 11 months, regular cycles, GF 35 weeks, 6 days, rheumatic heart disease, status post PTMC, done in 2013, moderate MS, mild MR, class 1 NIHA in sinus rhythm, not in failure, with single live intrauterine gestation in longitudinal lie cephalic presentation, not corresponding to her gestational age, with good fetal heart rate, with fetal growth restriction and oligohydramnios for further evaluation and further management.
Okay, so you had given the summary very well. Almost all points were included. Only thing not corresponding.
Madam, only one point, madam. Satyapriya, first you mentioned as moderate MR. In the summary and final diagnosis, you have mentioned as mild MR. You verify that.
Ma'am, in her last echo finding, it was given as mild MR, ma'am. So I continued with that diagnosis, ma'am.
Okay.
Now, one more thing is this, you're saying not corresponding to period of gestation means you must say it's less than the period of gestation. Second, remember when you're getting this patient in the examination, you won't have the echo findings and all. So you only have to say clinically what you have made out is a mitral stenosis. So only that actually this thing. MR is actually a echo finding, isn't it? And you won't know about the pulmonary hypertension. So you must, try to examine and get the history and present as you are doing in the examination. So actually, she's done, I don't know, all this is from the patient's own words, or you looked at her discharge summaries and all. The fact that she had a post percutaneous mitral commissurotomy and all.
Ma'am, patient, since she had studied her till BSc microbiology, she had some knowledge of her procedure, ma'am. So she was able to explain to some extent of what all happened, ma'am. So
It's
with
okay.
that,
It's nice to discuss like this, but then when you present, you must get. I'm sure she may not tell the entire percutaneous mitral commissurotomy. Very difficult for this thing. So she might have said, I underwent a surgical procedure like this in the Madri. She might describe. So it's better to get everything in the patient's own words. So if you practice like that, it will help you in the examination.
Okay, ma'am.
Okay.
Shall I proceed?
Before this, okay, so now you have diagnosed this patient. She's a 21-year-old young primate with now two problems. She has mitral stenosis as well as fetal growth restriction. Now, at the end of your examination, actually, you have to stratify risk for her. So, how will you stratify risk for any patient with cardiac disease?
First is her functional status, ma'am.
That is a NIHA class. So she belongs to NIHA class 1, which is a good thing. Any other risk stratification is there?
Ma'am, CARPREG scoring, ma'am.
Very good. CARPREG scoring. So what is the CARPREG score?
Ma'am, for her it is CARPREG score.
No, actually it is CARPREG, C-A-R-P-R-E-G.
Yes, ma'am.
Okay.
So shall I explain CARPREG scoring or should I tell it for her, ma'am?
You first explain what is a CARPREG score, then you say in the patient what is her risk score.
Ma'am, CARPREG scoring, it has a total of 4 predictors, ma'am, and based on
4 or 5? 4 or 5?
Ma'am,
Sorry, okay, tell me the predictors.
Ma'am, the predictors are, one is echo finding with a ejection fraction, left ventricular systolic ejection fraction of less than 40%, ma'am.
Very good, yes.
The other one is a left side outlet, left heart outlet obstruction with a mitral valve less than 2 centimeters square and aortic valve of less than 1.5 centimeters square, ma'am. Or left ventricular outlet gradient of less than 30 mmHg.
According to me, outlet gradient is not part of the CARPREG score.
Okay, ma'am.
Only size of the valve, left heart obstruction.
Okay, ma'am. And other any prior cardiac events.
Very good. Any prior cardiac event. Okay.
Yes, ma'am. Like stroke or arrhythmias or previous history of any CCF.
Okay.
Or whether if she belongs to NIHA class more than class 2 or presence of cyanosis, ma'am.
Or presence of cyanosis. Now 5 points are there, isn't it? NIHA class greater than 2, presence of cyanosis, left ventricular ejection fraction, then prior cardiac event and left heart obstruction. So in the patient, what are all the, how many points are there? Now suppose she has 0 point, the risk of an adverse cardiovascular event during that pregnancy is 5%. Okay, that means no. One is, suppose she has 1 factor.
7%, ma'am.
25%.
Yes, ma'am.
Greater than 1, that means 2 and above, she has a
75% chance of cardiac
75% chance of having an adverse cardiovascular event in pregnancy. So for your patient, how many risk factors she has?
Ma'am, she has 0 risk factors, ma'am. Since her ejection fraction.
Where 0 risk factor? NIHA class 1. Okay.
Mitral valve area, what is it now?
1.3 centimeters square, ma'am.
You only said less than 2 is a risk.
You said no?
Yes, ma'am. Okay, ma'am. She has, sorry, ma'am. So CARPREG score of 1, ma'am.
Okay. That means left heart obstruction with a mitral valve, this thing of less than 2 centimeters is a risk factor. So she has a 25% chance of having an adverse cardiovascular event in pregnancy. Next, any other risk, this thing you will see. There's another thing called the CARPREC2, which has some additional, some other 10 factors are there depending on this thing. Yes, very good. WHO risk score. You must see in which WHO group she falls.
Yes,
Okay.
ma'am. Yes. She belongs to class 2 or 3, ma'am.
Okay. Okay. So give me some examples of group 1.
Ma'am, group 1 is uncomplicated PS, pulmonary stenosis, mitral valve prolapse, or patent ductus arteriosus, ma'am, or any corrected ASD, VSD, or PDA, ma'am.
Okay.
Or,
so group 1 means the risk is no higher than the general population. Okay.
Yes,
group 2.
Group 2 includes repaired TOF, ma'am, or unrepaired ASD or VSD, ma'am. And most arrhythmias fall under group 2, ma'am.
Okay. Group 3. Just give me 1 or 2 examples.
Okay, ma'am. Group 3 is any mechanical valve, presence of any mechanical valve.
Replacement. Okay.
Yes, prosthetic. And cyanotic heart disease, any other cyanotic heart diseases, ma'am, such as
like the uncorrected TOF or something. Okay. And of course, group 4 is very important because these patients should be pregnancy is contraindicated. So what are the group 4 conditions?
Group 4 includes primary pulmonary hypertension.
Very good.
Native coarctation of aorta. And then Marfan's syndrome with aortic root dilatation.
Of more than?
You have to tell
more than 45 to 50 mmHg.
45 millimeters.
45 millimeters. 50 is for?
Bicuspid aortic valve.
Bicuspid aortic valve diseases, ma'am.
And then
or literally left ventricular systolic dysfunction, ma'am.
Okay. And in one more thing, what is Eisenmenger syndrome?
Ma'am, Eisenmenger syndrome is a reversal of shunts, ma'am. There is a right to left shunt, ma'am, with pulmonary arterial hypertension.
Normally itself, okay. Right to left shunt in cases of atrial septal defect.
Yes, some septal defects, ma'am. The septal defects, it is associated with pulmonary hypertension, ma'am.
Okay. So when the pulmonary pressures exceed the systemic pressure, there is a reversal of shunt, and this becomes a very dangerous condition. So at the end of your examination, you have risk stratified this patient using 3 things. One is a NIHA class, one is the CARPREC score, and of course, one is the WHO group to which she belongs. Okay. We'll continue. Then we'll see how to manage her.
Okay, ma'am.
Actually, the previous slide, please. The EDD is the 17th of March, you said, no? So
yes,
the age would be almost 37 weeks, no?
Yes, ma'am. Actually, it was the case history was taken a week back, ma'am.
Okay.
Upon her admission, she was basic investigations were done. Her hemoglobin was found to be 10.2, her platelets of 2.2 lakhs, total count of 11,200, urea of 18 milligram per deciliter, creatinine of 0.9, and SGOT of 22 and SGPT of 28. Total bilirubin of 0.8. Her outcome upon admission with the scan findings showing IUGR and oligohydramnios, patient was under continuous CTG monitoring, basic blood and urine.
Shall we look at the outcome at the end of our discussion? So we'll plan what to do for this patient. Okay, so as soon as you see her in the OPD, what investigations do you ask and what would you want to do?
Ma'am, first is her basic blood investigations, ma'am. Her hemoglobin should be checked, and her RFT and LFT should be checked. ECG should be taken at that time of admission, ma'am. And since she's a case of fetal growth restriction with oligohydramnios, admission CTG should be done, ma'am.
Okay, so let's have two groups of investigations. One are routine, two is related to the cardiac disease, and the third group is, of course, because of the fetal growth restriction. Okay, routine, we'll say. What are the investigations other than ECG at the time related to the cardiac condition?
Ma'am, echocardiography should be done, ma'am.
Echocardiography. And of course, usually ECG and echo only. Okay.
Yes, ma'am. Cardiology team should be intimated about the case, and cardiology opinion should be obtained at the time of admission, ma'am.
Okay, so generally it's always a what to say, combined combined consultation is always done. So what complications can you expect in your patient with mitral stenosis?
Ma'am, possibility of pulmonary edema, cardiac failure, arrhythmias, thromboembolic events. These are the possibilities of cardiac.
So how will you examine, suppose she's admitted in the ward or she's in labor, how will you examine her to rule out congestive cardiac failure?
Ma'am, she should be first, her vitals should be monitored, ma'am. Her pulse rate, her respiratory rate.
So what will indicate failure?
Ma'am, a heart rate of a tachycardia of more than 100 beats per minute, or a respiratory rate of more than
120. Okay, rising pulse more than and reaching 120 then.
Along with dyspnea, ma'am, patient with complaints of dyspnea, patient looks tachypneic.
Okay. Examination, what other important finding you look for? Tachycardia is one, then?
JVP, whether JVP is elevated or not.
You have a stethoscope in your hand.
Yes, ma'am. Auscultate the patient and look for any worsening of, look for any creps in case of pulmonary edema.
Basal crepitations, very, very important. Basal crepitations, especially even in labor, that's one of the first things to appear when the patient goes into congestive failure. Basal creps. Okay, then?
What about the abdomen?
Abdomen, look for any, first of all, look for pedal edema, ma'am. Pedal edema or abdomen, look for any organomegaly, ma'am, in case of...
Patient is in failure.
Look for hepatomegaly, ma'am.
Okay.
The hepatomegaly.
Okay.
What do you think this is spleen? Splenomegaly may be suggestive of an infective endocarditis.
Okay.
So what are the risk periods in pregnancy? When is she most likely to get into failure?
One is at 28 to 30 weeks, ma'am, when the cardiac output is at its maximum. And
Beginning
other is during
earlier in pregnancy?
6 weeks of gestation.
Okay, that is in the first trimester when the cardiac output is beginning to increase.
Yes, ma'am.
Next is, of course, 28 to 30 weeks when cardiac output reaches its maximum.
And at the time of labor and during the immediate postpartum period, ma'am.
At the time of labor. Why in labor?
Ma'am, at the time of labor, the patient, mainly because the patient, due to the contractility, the exertive efforts of the patient, ma'am, there is, and also pain causes a sympathetic reflex, which in turn increases the tachycardia, and it increases the cardiac output, ma'am.
Okay, so during labor, it acts like strenuous exercise. There is both increase in cardiac output as well as tachycardia, which worsens the hemodynamic changes in mitral stenosis. Then next. That is the first and second stages of labor.
During her
immediately after placental delivery. Why is there the maximum risk of congestive failure immediately after placental delivery?
Ma'am, there is during the once the uterus is emptied, the sinusoids start to close. So therefore there is an auto transfusion of blood of around 500 ml.
Very good.
So there is an increase in venous return, and also the pressure over the IVC is released. So there is an increase in venous return, and also there is extravascular blood fluid is shifted to the intravascular compartment.
That may not happen.
It takes a few more days, no? That does not happen immediately after delivery.
So immediately after placental delivery, it is a contraction of the uterus which pushes all the blood in the placental sinuses back into the venous circulation. So there's a massive auto transfusion. So I remember we used to load diuretics and keep, isn't it, to give immediately after placental delivery, because the risk of pulmonary edema is highest immediately after placental delivery. So it's called anticipatory diuresis. Soon as you deliver the placenta, you can give the diuretics in order to prevent this. So this thing is even faster during a cesarean delivery, because the baby and the placenta are delivered within a very short period, isn't it? Within a minute or a minute and a half. There is, so the damming back of blood into the placental circulation is extremely rapid in cesarean. And then, of course, the last is the first week of the puerperia.
Yes, ma'am.
So infections and then thromboembolic manifestations are higher. Okay. Okay, as during pregnancy, we already saw one or two. What are the conditions which increase the risk of congestive failure?
Anemia.
Yes.
Fever.
Infections, any infection, urinary or respiratory infections.
Thyrotoxicosis.
If she has.
In case of a multi-fetal gestation. Preeclampsia.
Okay. Excessive weight gain.
Excessive weight gain.
Anything else about pregnancy? So before we go on to labor, suppose she has repeated attacks of pulmonary edema in pregnancy. What are you going to do?
Ma'am, first is she has to be continuously. She should be admitted at the tertiary care center at all times, ma'am. She has to be continuously monitored, and she should be started on rate control drugs, diuretics.
You've already put her on metoprolol, no? She's already on Lasix. What else can we do? She's already had a PTMC. So what else can we do?
She's already going into class 4, class 3 or class 4.
Ma'am, if at all she is still in her first trimester, then we can suggest.
Talk about your patient, doctor.
In my patient, then
we may have to go for a valve replacement, no? Though we would not want to do it in this.
What is a safer procedure? Not in this patient. I don't know whether she's fit for that. But what would be the safer procedure in pregnancy?
Valvotomy, balloon valvotomy.
Percutaneous balloon valvotomy. She doesn't have an open heart surgery. It is they can do a balloon valvotomy to increase the diameter of the valve so that it doesn't go into intractable pulmonary edema in labor. So in pregnancy itself, she has repeated pulmonary edema. That's a real risk when she gets into labor. What is the risk of open heart surgery?
Risk of open heart surgery.
Generally, we try to avoid it in pregnancy, isn't it?
Yes, ma'am. Possibility of infections, possibility of
any surgeries associated.
Possibility of miscarriage, ma'am.
Okay. Second trimester. So when they do open heart surgery, you have to go into a pulmonary bypass, isn't it?
Bypass, yes, ma'am.
So that you will not be able to maintain placental circulation if there is a by cardiopulmonary bypass, placental circulation may be compromised. So fetal loss is extremely high as almost 40%. So that is why you try to avoid open heart surgery.
Okay.
Rani ma'am, anything about pregnancy? Then we can go on to labor.
If the like you were telling, no, you want to decide for this patient because she's got IUGR. Is induction of labor permitted in a heart patient?
Ma'am, it is induction of labor is not contraindicated, ma'am. Induction of labor can be done preferably with a mechanical induction, ma'am. With prophylaxis of infective endocarditis prophylaxis, ma'am.
What about cerviprime? Can we use PGU2 gel?
Cerviprime is avoided, ma'am, because it causes vasodilatation. It may result in pulmonary edema, ma'am.
Not always. No? We do use PGE2 gel in heart patients.
Okay.
And when you use Foley's as a mechanical for dilatation, you should follow aseptic techniques. You should not cause any ascending infection. Okay.
What about oxytocin? If you're giving oxytocin, what should you do?
Ma'am, we have to use a concentrated oxytocin to avoid
Solution.
food overload.
So it's better to give the oxytocin in an infusion pump, syringe infusion pump, rather than the usual way, so that you reduce the fluid which you give. Now, how will you decide the mode of delivery?
Ma'am, mode of delivery, vaginal delivery is preferred over cesarean section, ma'am. In most conditions, in most cardiac conditions, ma'am.
So what will be the indications for cesarean section?
Ma'am, pulmonary artery hypertension, aortic stenosis, mitral stenosis with atrial
Not aortic,
fibrillation.
you have to say severe aortic, not for all patients with aortic stenosis or all patients with pulmonary hypertension. Do we do cesarean?
In case of Eisenmenger's, ma'am.
It will be very risky. Remember, cesarean, all the hemodynamic changes are extremely rapid, so you may not be able to this thing. So what will be coarctation of aorta? That's one. Because there is
with the aortic root dilatation, wherever there's a risk of aortic dissection, you may have to straight away take her up for a cesarean. Okay.
In a coarctation, in addition to the risk of aortic dissection, you also have it can be associated with something else.
Aneurysms.
Aneurysms. So you can have cerebral hemorrhage. So those are conditions where you have to do a cesarean. So in all other patients, vaginal delivery is best for these patients. Let's say your patient did not have IUGR. She's in labor now. So how will you manage labor in this patient? She's 37 weeks in spontaneous labor.
A patient has to be first placed in a semi-recumbent position with a lateral tilt, ma'am. Oxygen vitals should be monitored using a multi-para monitor, ma'am. And oxygen should be given, ma'am. Oxygen O2 supply should be there, ma'am. And IV lines should be secured. Fluid overload should be avoided, ma'am. And
what about IV prophylaxis? What about IV prophylaxis?
Yes, ma'am. IV prophylaxis should be given for all cases.
Some guidelines say that IV prophylaxis is not routinely required.
Not routinely required, yes, ma'am.
So there are changes in the current recommendation. IV prophylaxis is not routinely given. What are the indications for IV prophylaxis?
Ma'am, according to American Heart Association, they have recommended for high-risk cases, ma'am.
Which are they?
Ma'am, they are patients with cyanotic heart diseases, ma'am.
Very good, yes.
With mechanical
prosthetic valves.
And in previous history of any infective endocarditis, ma'am.
So these are the three must indications for endocarditis by prophylaxis. Okay.
Other than that, patients with any possibility of intervention, ma'am, any kind of outlet, if at all we are going to go for any instrumental delivery, or in case of if at all there is need for a manual removal of placenta, in such cases again, in
heart disease, do we not use an instrument?
Yes, ma'am. We do, ma'am. So that is why
we
it
always
is
help her
recommended.
out, no?
Yes, ma'am. So in
Which
such,
is a
so in
preferable
that
instrument.
case, it is preferable to give an IE prophylaxis for all cases going in.
Though the guidelines say that it is not required, we still continue to give, no, in our setup.
Yes, ma'am.
So which is the instrument which would be preferred?
Vacuum delivery is preferred over outlet, ma'am.
Generally, we prefer outlet forceps over vacuum, no? Because in vacuum, the patient also has to
Her maternal efforts is needed for
yeah,
vacuum
maternal
delivery.
efforts are required, is it not? So forceps
Yes,
would
ma'am.
be a preferable instrument.
But again, in outlet forceps, patient is should be placed in lithotomy position, which increases the venous return, ma'am. So
Not necessary, ma'am. We can just apply the forceps also with with experience. You can do it. You don't have to put her legs up on the stirrups.
The
Okay.
outlet forceps is only for extension of the head. So you don't require this thing.
Lithotomy.
What else in the first stage? Fluids, what fluids will you give her?
ma'am, normal saline. Sorry, ma'am. Sorry, ringer lactate is preferred, ma'am.
What fluids are advised in patients with cardiac disease?
Ma'am, oh, sorry, ma'am.
Oral
Actually,
fluids. Do
oral
not give
oral
IV fluids if patient.
oral
First stage
hydration.
is better. If you need for some reasons to give IV fluids, it should not exceed 75 ml per hour. What is the heart disease where fluid restriction could be dangerous?
Fluid restriction is aortic stenosis, ma'am.
Very
Where the
Aortic
patient should be
stenosis, you have to be very careful about fluid restriction because you restrict fluids, the cardiac output will fall. Okay. Then what about analgesics? So labor is a very painful process.
Yes, ma'am. Epidural analgesia can be provided for the patient, ma'am.
Okay, so what are the advantages of epidural analgesia?
It relieves the patient from pain, ma'am, which again.
Okay, so it gives excellent pain relief. Nothing can actually this thing. Then
it keeps the patient in a state of hypotension, ma'am.
Not hypotension because of peripheral vasodilatation.
Dilatation, yes, ma'am. There is decreased.
It reduces the preload. Okay, then.
So where can that be dangerous?
Ma'am, in case of coactation of aorta, in case of aortic stenosis, ma'am. In cyanotic heart diseases and.
It can cause reversal of shunt, no?
Yes, ma'am.
Then what is the other advantage? It reduces catecholamine release. Very important. Sympathetic activity it reduces. So is there any what to say disadvantages? Hypotension. In aortic stenosis, it can be little dangerous. Plus, if the patient is on anticoagulants, you have to find an adequate window to place the epidural. For example, she might have had heparin just 6 hours later. So in which case, in early labor, it may not be possible to place the epidural catheter. Okay. Second stage we saw. What about third stage of labor?
Ma'am, in her third stage of labor, the patient should be given diuretics, ma'am. 40 mg of furosemide should be given stat, ma'am. And
active management?
Active management of third stage of labor should be carried out, ma'am.
Okay.
Vitals should be monitored continuously and look for any signs of cardiac failure, ma'am.
Can we give PGF2 alpha?
No, ma'am, it is preferably avoided, ma'am.
Misoprostol is preferred over PGF2 alpha, and also methyl ergometrin is absolutely contraindicated.
Contraindicated, ma'am.
Now, if the patient were on anticoagulants, let us say you have a patient, this patient underwent a valve replacement and she was on anticoagulants. So how will you manage anticoagulation in pregnancy and labor?
Ma'am, patient is preferably if the patient has been on warfarin for more than 5 mg, then she is changed to heparin. from the period of conception till 12 weeks of gestation, ma'am. From 12 weeks to 36 weeks, she is advised to continue with warfarin, ma'am. And after 36 weeks, again she's changed to heparin, ma'am.
Okay. And when will you stop the heparin?
Heparin should be stopped 24 hours before surgery, ma'am. Before the procedure, ma'am.
In heparin, you have unfractionated and low molecular weight heparin, no? So you have to tell us both.
In case of unfractionated heparin, it has to be stopped.
About 6 hours, 4 to 6 hours is enough for an unfractionated heparin. Whereas the low molecular weight has a longer duration of action. So it has to be at least 24 hours after the last dose if you're going to induce the patient or she's going to be taken up for cesarean. So when do you restart?
When it is restarted after 24 hours, 6 hours in case of a normal delivery and 24 hours in case of cesarean section, ma'am.
And do we keep her on heparin?
No, ma'am. It has to be switched over to warfarin with an overlap of around 3 days, ma'am. And the INR should be maintained between 2.5 to 3.5, and she can be advised to continue with warfarin thereafter, ma'am.
Okay, so that is the bridging.
Yes, ma'am.
What about breastfeeding?
Breastfeeding, breastfeeding can be continued, ma'am, with warfarin. Though there is a minimal secretion, but it does not affect the fetus in a major way, ma'am.
Okay. When patient is on low molecular weight heparin, how do you monitor? What do you have to monitor? INR is oral anticoagulation.
After anti-10A, ma'am.
And unfractionated heparin?
Unfractionated heparin with APTT, ma'am.
And INR.
And INR, okay.
What disadvantage with the unfractionated heparin?
Ma'am, longer in case of it may cause thrombocytopenia, ma'am, and it can also cause osteoporosis in some patients, ma'am.
Use bone mineral density, especially the platelet count. You should be very cautious.
Yes, ma'am.
What about contraception?
Ma'am, contraception, barrier contraception is preferred, ma'am. But IUCD can also be.
Failure rate is very high, no?
Failure rate is high, ma'am. Failure rate is high. So IUCD can be advised but it has to be started with IE prophylaxis, ma'am.
Do you not use
progesterone only pills can also be suggested, ma'am. Progesterone only pills can also be.
You can give IUCD, no? Yes, that's what we do most of the times. Of course, progesterone only pills can be given. They are the best options, but it is not even really available. You have other ways of giving progesterone?
Implants, ma'am.
What is available? First, you tell that. No? What is available in all the hospitals?
DMP. They have to tell the project.
Ma'am, Antara, ma'am.
Yeah, Antara.
Project and then what other form it is available?
Implants, it can be given as implants.
And LNG?
LNG IUS, ma'am.
Okay. Suppose the patient has this is a second delivery. Would you advise sterilization?
Ma'am, we would counsel the partner to have a vasectomy, ma'am. Preferably.
Not be always willing, ma.
It can be done at like after 7 days, ma'am. We can give a time of 7 days.
Yes, after 7 days.
No, ma'am. Or interval sterilization could be advised, ma'am.
Yeah, so you can give her a temporary contraception and see if she is stabilized after her puerperim and do it as an interval procedure. What about laparoscopy?
Laparoscopy. Ma'am, in case of ma'am, it is not preferred, ma'am, because she will be subjected to ma'am, it can the distension can not sure, ma'am.
Laparoscopy is definitely contraindicated as far as our anesthetists, they will never give a fitness. Especially patients with cyanotic heart disease and patients with Fontaine's and such patients, we generally don't advise laparoscopy.
Okay.
Able to do a TAT.
Satyapriya, you can stop sharing, no?
Okay.
One last question. Sometimes now we see patients with ASD, VSD and all. Generally, they tolerate pregnancy well. But will you have any problems with ASD, VSD patients in pregnancy and labor?
No, ma'am. Usually, it's ASD, VSD patients do not. They have an uneventful.
Yeah, uncorrected ASD, VSD.
Yes, ma'am. Uncorrected ASD do not have any. They may mostly go in for an uneventful cardiac events during her.
Uneventful pregnancy and labor. But what are the one or two things you have to be very careful about? So what are the complications?
Pulmonary hypertension.
Pulmonary hypertension actually comes with age only. The longer the shunt is there, it goes on this thing. So in pregnancy and labor, one thing is the tachyarrhythmia. Second is hypotension. You must avoid hypotension. If the patient becomes hypotensive because of massive postpartum hemorrhage, the systemic pressure will fall below the pulmonary pressure. So there can be an acute reversal of the shunt. So that is one thing that we have to be careful, because in labor, so many events can cause hypotension. So if you just say ASD, VSD patients will not have problem, we have to be very careful to avoid hypotension in labor.
What is PPCM? We cases, no?
Yes, ma'am. Ma'am, it is a form of dilated cardiomyopathy, ma'am, without any unknown cause, with no prior history of heart disease in the last month of pregnancy within 5 months postpartum, ma'am.
Okay.
Under
which WHO class would it come?
Ma'am, it comes under class 4, ma'am.
Not always, ma'am. Only when there is a
residual left ventricular dysfunction.
She will come under 4. Okay. So does it tend to recur?
Ma'am, yes, ma'am. It does tend to recur, ma'am. In case of if it is completely recovered, then the possibility of PPCM in the next pregnancy is around 20%, ma'am. And in case of if there is a residual dysfunction, then the possibility is around 45%, ma'am.
How do you treat? And what's the etiology?
I'm sorry, ma'am. Etiology, it is usually seen in around 20 to 25 years of age, ma'am. And the other includes multiparity, ma'am, multifetal gestation, and it is seen in case of preeclampsia hypertension, and it is more commonly seen around in Black women, ma'am.
Okay. What could be the cause?
Cause is either viral mediated or immune mediated, ma'am.
Okay.
Coxsackie or encephalomyocarditis.
Okay. And how is it treated? Nowadays, they are even suggesting that the breakdown of prolactin, no?
Yes, ma'am. Bromocriptine is now being suggested as one of the treatments, ma'am. So in case of a PPCM, first we have to ensure that the saturation is more than 95%, ma'am. And the oxygen should be supported with oxygen, and she should be placed in a propped up position, and IV fluids should be avoided, and she has to be given with she should be started with diuretics, and then the rate controlled beta blockers, and she should be started with digoxin, ma'am, and she should be under continuous vitals monitoring.
there is a role for bromocriptine because of the
Yes, there's a lot of bromocriptine.
it helps in that suppressing the lactation and also to improve the left ventricular function.
Other students, if you have any doubts, you can post in the chat box.
So we look at the chat box. I think Satyapriya did a good job.
Yes, ma'am.
My name is Archana, ma'am.
You're Archana.
Oh, Archana,
Because your name is coming under Satyapriya there.
No,
Okay.
actually, we have connected in a common system, ma'am.
So Archana, you did a good job.
Thank you, ma'am.
Congrats, Archana.
Thank you, ma'am.
Every last Saturday, we are conducting this PG program. See, we have good teachers. 1.5 hours, we are discussing only one topic. You please spread the message to all PGs.
Okay.
Somebody wanted a postpartum thrombolysis in detailed way. The chat box question.
Madam.
Timing of induction of labor.
Induction of labor is only for obstetric indications. You have to use certain precautions to induce that particular this thing. So certain things are contraindicated. I think we discussed in detail, no, induction of labor.
Usually we tend to induce at 40 weeks, ma'am. We don't allow the patient to go beyond dates.
Okay.
And we did discuss how we induce and all that.
Somebody wanted a cardiac examination and the significance of the findings. Cardiac examination in detail.
Okay, so cardiac examination actually begins with pulse and blood pressure. So general examination itself, there are many things that you have to sort of additional things you have to mention. What is the nature of the pulse? You have to and then you have to palpate the pulse in all the peripheral vessels. And then of course, central cyanosis, peripheral cyanosis, presence of pedal edema, jaundice, general examination, certain things are important. Cardiac examination, you have to do a thorough examination like you undergraduate cardiac examination, you must do, not that S1, S2 just heard. So you have to start with inspection. So in case the patient has had a scar on the precordium and if you miss it, no, it's a big this thing. So examine the precordium, see for any thrill, any bulge, any pulsations which can be seen in the precordium. Palpation, you have to look for the usual, where is the apical impulse, any palpable thrill, palpable P2 and parasternal heave. And then percussion generally is not done because we have other things to see for cardiac enlargement. Auscultation, you have to auscultate all the 4 areas of the heart. And if there is a murmur, you have to describe where it is best heard. What is the nature of the murmur? Is it systolic, diastolic, mid-diastolic, early, late? Similarly, systolic murmur, what is the loudness and is it conducted anywhere?
It was really wonderful, Sita Madam. Sita Madam and Dr. Rani, Dr. Bhagyavati and Dr. Thangattai. It was really good. Students nalla prepare pannirkeenga. Kandipa you can
They prepared.
University rank.
And the history and all, they had taken all the points.
Yes, madam.
Very nice.
Anyway.
Very good presentation.
Thank you, Sampath ma'am, for.
Thank you, madam. I screen podla.
Thank you, Anjalakshmi ma'am and Sampath ma'am for the opportunity.
Thank you, Dr. Ran.
Thank you, Anjalakshmi ma'am.
You are a good Navya Sri. Ellathukkume badil pottitunda, madam. One student, I don't know from which college, was giving answer for everything in the chat box.
Oh, okay.
Anyway, Kalpana. I myself will tell the vote of thanks. Really, I thank all the students, first of all, that Dr. Archana, Dr. Satyapriya for the wonderful presentation, and the teachers, external being Dr. Sita and Madam and Dr. Rani, and internal Dr. Thangattai and Dr. Bhagyavati. Madam, unmele students and alla train pannirkeenga, Madam. Thangattai Madam and Bhagyavati Madam.
Thank you, Madam. Thank you.
Thank all the students who have participated. And once again, I mentioned that on every month, 4th Saturday, we will be conducting the class from 5:30 to 7. Please spread the message to your colleagues such that we have a good teachers and good points. It will be very, very useful for your exam. And I thank our President, Dr. Anjalakshi Madam, for allowing me to do this program, and the coordinator, Dr. Kalpana. So I finished my vote of thanks, and finally I thank Shield for the wonderful scientific grant. Thank you. Thank you, ma'am. Sita, ma'am.
Thank you. Thank you, ma'am. I really enjoyed being part of the program.
Yes, madam. Ella masamum 4th Saturday pandro, madam.
Okay, okay, ma'am.
5:30 to 7, sometimes
Okay.
7:15, 7:30 also.
Okay, okay, ma'am. We'll
Only
tell her.
one topic.
Thank
Thank you, ma'am. Thank you, students, and thank you, teachers. We can read.
Thank you so much.
Thank you, madam. Thank you, madam. Thank you.
Thank you all teachers. Thank you, Rita,
Thank you, ma'am. Thank you so much.
Rani, and
Thank you.
Tangathai, madam, and
Tangathai
Oh,
and Subbalakshmi, yeah.
Okay, madam. Thank you,
Okay,
madam.
thank you so much. Students, I think they did well, I think. They answered
Wonderful.
all the questions, Rita.
Nalla pannanga, madam. Nalla
நல்லா பண்ணாங்க, ஆமா.
You come prepared, whatever doubt